This conference will now be recorded.
Welcome to MMR Accreditation Stage 1 Webinar 4. In the last webinar, we talked about community patients and home medicine's review. When you become accredited, you will be accredited to conduct RMMR as well as HMR. So you need to know a little bit about aged care. This webinar is just an introduction. We've got such a little time together, but I think it gives you just an overview of the things that you need to think about that connect RMMR. So the learning objectives after the webinar, pharmacists will be able to describe the principles, aims and scope of RMMR and QUM, explain the requirements under the current RMMR and QUM rules, explain the differences between HMR and RMMR. The current Australian health landscape indicates that we have an ageing population. There is an increasing prevalence and burden of chronic disease with decreasing mortality rates. That means there will be an increasing need and use of medications as well. There is a lot of information in the professional practice standards about aged care medication reviews. The slide shows the headings, so you can see that the service is very structured with procedures and comprehensive documentation. It is about patient-centred care and collaborative care. There are policies and procedures. You're doing education and training, but there is assessment and consultation, service delivery, documentation and data management, counselling, continuity of care, monitoring, review and follow-up, storage and disposal, risk management and evaluation. RMMR and QUM are two separate services and are funded under the Community Pharmacy Agreement. There are specific program guidelines and they're available on the Pharmacy Program Administration site, or the PPA. And of course, we have the PSA standards and guidelines. Happily, they all sound the same. Sure that these services have been around for some time and structure is appreciated by aged care facilities. Originally, of course, QUM was part of the RMMR service, but now it's a separate service in its own right. Let's have a little look at ageing to start with. As we age, several things happen. There are cardiovascular effects. Our heart rate becomes slower and our heart becomes bigger. Our blood vessels and arteries become stiffer, causing the heart to work harder and pump the blood through. Our bones tend to shrink in size and density, and that makes the bones weaker and more susceptible to fracture. Muscles generally lose strength and flexibility, and people become less coordinated and have trouble balancing. Constipation is more common in older adults as well. Many factors can contribute to constipation, including a low fibre diet, not drinking enough fluid, lack of exercise, maybe medicines. A loss of bladder control, urinary incontinence is very common with ageing. Medical conditions such as diabetes might contribute. And menopause for women and enlarged prostate for men. Many might become problems. We may also have a loss of vision, loss of taste and hearing. It's a factor to account when you're conducting an RMMR. It's no wonder we'll need a high level of care. These headings are a very, very brief overview of the aged care structure. Let's for a moment consider aged care accreditation. You may be asked by the staff at the facility to help with aged care accreditation. Their accreditation, like pharmacy, requires documentation that indicates what they are doing is actually what they are saying. Or maybe the other way around. Unlike pharmacy, if they do not pass accreditation, their funding is withdrawn. Another topic you will hear is ACFI. ACFI stands for Aged Care Funding Instrument, and it allows staff to assess residents to find the type of care that's needed, and funding is then based on a formula. Staff in aged care seem more structured than in pharmacy. The Director of Nursing is sometimes called the DON or the General Manager. RNs or registered nurses are responsible for management of residents, but often the people who actually care for the residents are enrolled nurses or ENs or assistant in nursing or AINs, or sometimes care staff. Contracts are another thing that we need to talk about. You may be aware that RMMR and QUM both need a contract between the person providing the service and the facility. So it's possible that there will be a contract for dispensing, one for RMMR, one for QUM. And all services could be with different entities. Just a very, very quick word about aged care standards. The new standards have 8 sections. The first one is consumer dignity and choice, ongoing assessment and planning, personal care and clinical care, services and support for daily living, organisational service environment, feedback and complaints, human resources and organisational governance. Each of them has quite a large number of pages to cover. So we've summarised the residents' rights. As you can see, they're quite long, but I think it's important to spend just a small amount of time on them. The Charter gives individual protections so that if you were in an aged care facility, you can say, I have the right to safe and high quality care and services, to be treated with dignity and respect, to have my identity, culture, and diversity valued and supported, to live without abuse and neglect, to be informed about my care and services in a way I understand, access all information about myself, including information about my rights, care and services, have control over and make choice about my care and social life, including where choices involve finances and possessions. I have my independence. I should be listened to and understood. I should advocate, support me or speak for me on my behalf. I should be able to complain free from reprisal and have my within a fairly and prompt way. I should have personal privacy and have my personal information protected. I should exercise my rights without it adversely affecting the way I am treated. A little bit about entry into aged care. There is a team at all the local hospitals called the Aged Care Assessment Team, or ACAT. We don't really have to know anything about them except that ACAT assessments often have quite a comprehensive diagnosis on their assessments, which is very good when you're doing an RMMR. I've also given you a website here to find an ACAT team, just so that you can be aware where they are in the hospitals. So a little bit about the aged care funding instrument. It's the formula by which aged care facilities are remunerated for patient care. And there are 3 areas based on time spent on care. So there's activities of daily living, behaviour and complex health care. So activities of daily living would be dressing, bathing, feeding, just general things. Behaviour might be if someone has and they're wandering and they need someone to chase them up all the time. Complex healthcare might be giving insulin, some kind of injection on a regular basis. And subsidies are paid at 3 levels. So high care, medium care, and they actually time how long it takes to do all the activities that they need to do. Many assessments, such as pain assessments, were not routinely done before ACFI, so there's actually a lot more information about the patient available now. And you really probably are aware that low care residents are not too many around. So the other assessments that are done in ACFI are continence, pain, and the Psychogeriatric Assessment Scale, or PASS, which tests cognitive impairment. Behaviour can be wandering, it can be verbal or physical, and they also do a Cornell scale for depression. So how does this fit in when you're doing a medication review? I think it's important to realise that if you were conducting a medication review, you might find that the patient was reporting incontinence. When the ACFI was done, they may have been continent, and now the staff will have to provide extra care. So a new assessment may need to be done. So medication review can be really quite effective for facilities. Somebody may be in pain and they haven't reported it to somebody having going on. The community pharmacy agreement programs are subject to cost effectiveness assessment, and the agreement that's underway currently has fund allowed for RMMRs and QUM at $14.2 million. So RMMRs, they must be conducted by an accredited pharmacist in collaboration with a GP. While anyone can identify the resident for RMMR, the referral is started by the GP for permanent residents. The aim of each review is to identify, resolve and prevent medicine-related problems. This is done by collating information about the resident's medicine and completing a comprehensive review. Obviously, the outcome is hoped to enhance their quality use of medicines and provide optimal benefit for the resident. To become an RMMR service provider, there must be an RMMR service agreement. This is the agreement between the facility and the pharmacy or an accredited pharmacist or an entity that can provide an accredited pharmacist to conduct the service. No RMMRs will be remunerated if they are done before acknowledgement of the service by the PPA. The service provider is responsible for ensuring the agreement entered into is consistent with the RMMR and QUM program guidelines. Only one RMMR service provider is contracted to a facility. So what do they need to do as be an eligible service provider? Firstly, they have to be approved by the Pharmacy Program Administrator or PPA and abide by their conditions. They have to provide RMMR and or the QUM service in accordance with the program guidelines. All elements of the RMMR service must be done by the same accredited pharmacist. So what about the resident? Who's eligible for an RMMR? Firstly, the resident must have a current Medicare or DVA card. They're at risk or currently experiencing medication misadventure, and be a permanent resident of an Australian government-funded residential aged care facility, as defined by the Aged Care Act in 1997, or be in a multi-purpose facility, which is often in a country area, or be a resident of an Australian government-funded transition care facility for more than 14 days. And their GP confirms there is an identifiable clinical need and the patient will benefit from an RMMR. So let's look at how often RMMR can be conducted. One service can be conducted per eligible resident on the referral from a general practitioner. A subsequent RMMR may only be conducted if more than 24 months has elapsed since the date of the recent patient interview, or when the resident's GP specifically deems a clinical review is necessary. And that could be when there's been a significant change to the condition or the medication regimen. Now, I have to ask you here to note that Medicare item 903 says every year. It's only the pharmacy side that says every 24 months. So, RMMR referral. Patient consent is needed. So, at the facility, the doctor says, I'm going to do RMMR as part of my service at the facility. Anyone can identify the need for an RMMR, so it could be the pharmacist or the nursing staff, the allied health or specialist, but it must be initiated by the resident's GP. The written referral should include reason for referral and all relevant prescribing clinical history to the RMMR service provider. This may or may not happen. Sometimes what happens, they just write, do RMMR in the notes or on a fax and send it to the service provider. And you have to look for information. So on the one-day workshop, we will have a chat about that. You can see that the service is collaborative, though, in the same way to HMR. The GP and the pharmacist working together, but this time it's with the aged care staff. There are other Medicare items that fit with RMMR. So, for example, the doctor can do a regular visit. They can do a comprehensive medical assessment or CMA, and that's actually paid or remunerated to the GP based on the time they take to do the CMA. So it can be just a brief one or a standard one, a long one or an extended one. Usually an extended one would be something that happened on admittance to an aged care facility. So it can take quite a while to get all the information about the resident and actually document everything. And of course, a case conference. Case conference is where the GP has two other people and they talk about the resident. So it can be a nurse and the pharmacist, or their own nurse and another nurse at the facility. But it's often the pharmacist that's involved in these case conferences. RMMR can be the result of a CMA and lead to the case conference. But what can happen is that sometimes staff, that this RMMR can start the CMA. That helps the doctor complete the annual CMA, and also it can lead to the GP actually adding to the care plan at the facility. So let's have a think about the review process. It's very to HMR. Do you remember the 10 steps? It's not always possible in aged care because residents sometimes have a stroke and can't talk, or they're simply too ill to speak. Maybe they have dementia and their information is not reliable. Once when I was testing out an interview form to see if all the information we asked was enough, I interviewed an elderly lady in a facility and it all went very well. As I stood to say thank you and goodbye, she asked if I would come again and see her. Of course, I said yes. And then she said, "Don't leave by that door because everybody that goes out that door never comes back." And that door turned out to be the wardrobe door. It made me wonder about the information that I had carefully gathered. Even if you cannot do an interview, just seeing the resident is a good idea. As an example, if they're asleep at 11 o'clock in the morning, that might tell you something about their nighttime medications. The next stage of the process is the clinical assessment and written report. The report is provided to the referring GP and the facility with discussion of relevant findings and suggested management strategies. To do all this requires knowledge of, access to records on each resident, but the same accredited pharmacist must do all the steps. Just a reminder about the communication needed in RMMR. You need to be empathetic to both residents and staff and be thoughtful about gaining information. You must also utilise the skill in non-judgmental in your language. If, for example, you found the charts weren't signed, what would you say? So what are the steps in the clinical assessment? Firstly, the medication chart. This gives reliable information on medications, allergies, dose and regimen. GPs write up the chart, sign it and date it, and use a date to CSEP medication if they need to. Nurses must sign for administration, so it tells you if the medicine that's been ordered has been administered. For those who've never done any work in aged care, on a medication chart, A means the resident was absent and the medication wasn't given, and R means the resident has refused. The admission form is quite useful as well. The GP notes and nursing care notes all have information about the resident, the diagnosis, medical and surgical history, and current condition. Sometimes these forms now are all electronic, so you have to have access to the facility information. Other information that's useful could be GP notes. There could be a diagnosis in the GP notes to support each medication. If the pathology is available to verify drug levels, that's a good idea. It can support the diagnosis as well and give information on the resident conditions so you can check their renal function, their thyroid function and hepatic function. It's also helpful if you've got electrolytes. So we've suggested that you calculate creatinine clearance, use an interactions program, check that there's no duplication of therapy, check that there's no diagnosis that's untreated, and check that there's treatment for the diagnosis that isn't noted. Maybe check that the treatment's working. So, do we gain remuneration for RMMR? Yes, we do. They must be claimed in the following month after the date of interview. Claims submitted outside of this time frame will not be paid and cannot be resubmitted. Claims must be lodged online using the PPA registration claiming portal. RMMR can be claimed immediately and are paid soon after claiming. The payment is quite quick, so there's no need to wait till the end of the month to prepare a claim separately. While we're talking remuneration, I want you to consider the difference between RMMR and HMR. RMMR is for the aged care resident, HMR is for the community resident. Aged care residents are unlikely to be non-compliant, but community residents are. Often you'll be asked to do more than one RMMR at a facility, but HMR is always a single service. HMR interviews are integral to the service, and you will not be remunerated if there's no interview. RMMR interview is not compulsory. Both are started by the GP and both have reports for the GP. I want to move now to the QUM program. This is not part of your preparation for accreditation, but this is an overview of the service because you may be asked to conduct this service as well as RMMR, so it's important that you know the process. The QUM service can be provided by an accredited pharmacist or a registered pharmacist. It focuses on improving practices and procedures as they relate to the QUM. There needs to be a service agreement for the QUM service as well as the RMMR. So the objectives are quite complex. Advise members of the facility healthcare team on a range of medication management issues to meet healthcare needs of the resident. Provide medication information and education to residents, carers, other providers. Assist the facility to undertake continuous improvement activities, including ensuring medication management accreditation standards are met and maintained. Just a bit of an overview. Firstly, you would meet with the facility to look at what they want for their quality use of medicine service and decide on the dates for the service. Usually it's every 3 months. You attend a MAC meeting or medication meeting. We're going to talk about each one separately, but I just wanted to do an overview first. You can conduct drug usage evaluations. These surveys need not be complex, but must be useful to staff and lead to improvements in medicine use. Conduct staff education, provide newsletters to staff, and of course make the claim. I like the idea that the surveys and education are connected because that helps staff gain better outcomes. So just as an example, conducting a survey on the use of PRN pain medications can be connected to an education on pain management. So looking at each component of the service, the MAC meeting, these meetings have become a policy making meeting and need an agenda. They're quite formal. They usually run for an hour and they're usually every 3 months. Sometimes they're breakfast meetings or lunch meetings to encourage everyone to go. I'm hoping that you would be able to prepare an agenda. It's really a list of what you want to talk about, so it's not very complex, but we will do a little bit more on this on the one-day workshop. So education. So the topics are up to the staff and to you, and they can be set for the following year as a because they're often the staff have other providers. It's usually run for 20 to 30 minutes and are every 3 months. It doesn't have to be a formal presentation, but I find it's easier to have users. Surveys of medicine use or drug use evaluations are useful tools to improve medication management. Again, be sure to collaborate with facility staff about what you think and what they think would be useful. They won't take any notice otherwise, so I think it's important that it's valuable to them. So just some ideas. So you can look at how often PRN medications are given. You can look at how often pain medicines that are PRN ordered are given. You can look at how many people are on benzodiazepines. You can look at the connection between diuretics and incontinence, because often older people don't make it to the bathroom quick enough and they will be incontinent. You can look at all the crushed meds. You'll be very surprised when you look at the crushed meds to see what they're crushing. And then you can look at things like anticholinergic or inappropriate medicines for the elderly. There's a summary of the QUM activities. advising the healthcare team on medication-related issues. It might be storage, it might be administration. The MAC or policy development. So just to put that into perspective, things that are put to the MAC might be something like nurse-initiated medication, and that then goes to staff training, so everybody knows that the changes have been made, and then it's actually implemented on the floor. DUEs or surveys of medicine use, and of course education. Let's consider how the service is remunerated. The QUM service fee is a base annual amount of $240 plus a fee per eligible bed. The QUM payment is based on eligible beds, not beds that are filled. It's paid to the registered service provider quarterly in arrears, so you work for the first 3 months before you get any funding at all. The quarterly period commences on the date the service agreement between the facility and the service provider is signed. So if you sign the agreement on the 1st of January, you would be able to claim then on the 1st of March. The QUM service startup looks like this. So firstly, you'd inquire if the facility was actually having the service done by anyone. If they weren't, you explain the benefits, check the number of beds and prepare a contract, sign to the PPA, wait for acknowledgement, and then start the service. So this is a very important document for you when you're doing RMMR and QUM. It's called the Guiding Principles for Medication Management in Residential Aged Care Facilities. And yes, it is October 2012, so it hasn't been updated because they think it's perfect. It'll be your major reference guide, so let's have a look. There's information about medication advisory committees, there's terms of reference and an agenda, complementary and non-prescription medicines using the National Medicines Policy, nurse-initiated medicines, what standing orders are and emergency stock, which New South Wales Government now call this urgent use medication, medication review and reconciliation, which is done when a resident returns from hospital, storage of medicine and disposal, self-administration of medicines by residents, medication charts and medicines administered by staff, DA continuity of supply, information on altering dose. We've mentioned many resources and guidelines for you, but there are a couple more. The Silver Book by the RACGP is where GPs find structure in treating aged care residents. And the Department of Health has a great resource that supports guidelines for medication management in New South Wales. I'm guessing the other states do as well. As said before, always talk about the money last. At the one-day workshop, you'll be asked to consider how to manage a business using these professional services. So we hope you've enjoyed webinar 4 of the MMR Stage 1. Please continue now to the assessment and evaluation, and we look forward to seeing you soon.